We are talking generally about the topic of oncofertility, and more specifically about reproductive endocrinology and infertility referral for fertility preservation in patients undergoing chemotherapy or gonadotoxic therapy, as the poster said. And we're joined by two members of the OBGYN department, both who are relatively young in their careers. I don't actually know who's going first, and I'm going to introduce both of them together as we start, and they can decide that. So we have two speakers. We have Tanya Glenn, who's originally from Rochester, Minnesota, and went to college at Truman State University in Missouri. And then went on to attend medical school at St. Louis University School of Medicine, and took what is not such a common path of joining the military, and did a combined military and civilian residency at Wright-Patterson Air Force Base and Wright University in Dayton, Ohio. She's in her final year of REI training at Yale and is going to be taking a position at Brooks Army Medical Center after completing her fellowship this year. And she is joined by Gabriela Beroukhim, who is from Los Angeles, originally received her undergraduate degree at UCLA, where she received a number of honors, and went on to medical school at UCSF. She is a third-year resident in OBGYN and is also interested in REI, and is in the process of applying for reproductive endocrinology and infertility fellowships. As the parent of a child who went through the Yale OBGYN residency, it's always nice to interact with Yale OBGYN residents. So they're here today, and I'm not entirely sure what order. I'm not entirely sure who's talking about what, but I'm going to leave it to the two of you. You're both on one screen, and I think you can figure it out. Welcome. Thank you for joining us.
Thank you. Thank you for having us. So I'm Gabriela. I'm here with Dr. Glenn. We're actually going to be co-presenting, and Dr. Glenn is going to help answer questions at the end as well. Okay.
We can see your slides. They look perfect.
Perfect. Thank you so much. So today, as you already mentioned, we're going to be talking about fertility preservation for patients undergoing gonadotoxic therapy. Neither Dr. Glenn nor I have any disclosures. So our objective with this talk is to try to raise awareness for fertility preservation, encourage patient and provider discussions surrounding the implications of cancer treatment on future reproductive capacity, improve multidisciplinary collaboration between providers caring for these patients and reproductive specialists, and discuss options for fertility preservation for patients who hope to preserve their reproductive capacity. So first, I'd like to start with a little bit of background on this topic. The term oncofertility was coined by Dr. Woodruff, and it refers to a field of medicine concerned with minimizing the negative effects of cancer treatment on the reproductive system and fertility, with assisting individuals with reproductive impairments resulting from cancer therapy. So what population are we referring to when we discuss fertility preservation for patients undergoing cancer therapy? So over 200,000 people under the age of 49 are diagnosed with cancer annually, and 85% of patients less than 39 years old will survive for 5 years. 70,000 new cases a year of cancer are diagnosed in adolescents and young adults. Of these patients, more than 90% of them will survive for at least 5 years, And these patients tend to be healthier and tolerate more intense therapies, which is relevant because more intense therapies can drastically reduce the reproductive lifespan. Certain cancer treatments, such as radiation, chemotherapy, and surgery, can lead to sterility and subfertility. So next, I'd like to briefly discuss what some of the morbidities are of these therapies. So specifically regarding radiation therapy, there are acute morbidities, including primary hypogonadism, premature ovarian insufficiency, which was previously referred to as premature ovarian failure, central hypogonadism, specifically for patients who are undergoing radiation to the brain. And then there are late morbidities, including secondary cancers that can result from radiation therapies, hypothalamic pituitary ovarian axis deficiencies, spinal cord dysfunction, which can potentially lead to impotence among males, and infertility or ovarian insufficiency. Regarding the effects of chemotherapy, there are the effects of late morbidity, including infertility, premature ovarian insufficiency, and primary hypogonadism. And there are increased risks, specifically with people who are receiving alkylating agents or patients with Hodgkin's lymphoma or breast cancer with undergoing adjuvant therapy who are at increased risk of premature ovarian insufficiency. Regarding stem cell therapies and the effects of those can lead to gonadal dysfunction, and the late morbidity associated with those include secondary cancers and endocrine dysfunction. Lastly, there are the surgical effects of cancer therapies, and the acute and long-term effects of those include early menopause and sterilization. For example, if somebody would need to undergo removal of their ovaries or fallopian tubes. So different therapies have different reproductive risks associated with them. So high-risk therapies include high-dose pelvic radiation, radiation to the brain, hematopoietic stem cell transplantation, total body radiation, or chemotherapy with high-dose alkylating agents. Whereas low-risk therapies include low-dose radiation to the pelvis, non-alkylating chemotherapeutic drugs, or antimetabolites. So now I'd like to transition a bit to discuss the importance of counseling these patients. So all patients of reproductive age who will undergo potentially gonadotoxic therapies should be receiving fertility counseling. This is in line with guidelines from the American Society of Clinical Oncology, which reports that all oncologic healthcare providers should be prepared to discuss infertility as a potential risk of therapy. The NCCN practice guideline also says that fertility preservation is an essential element of management of adolescents and young adults with cancer. That being said, less than half of US doctors inform cancer patients of childbearing age about fertility preservation, and only 47% of US doctors routinely refer cancer patients of childbearing age to reproductive endocrinologists. 54% of oncologists do not discuss fertility, according to the JNCCN that was published in 2013. Whereas specifically pediatric oncologists tend to do a bit better, and 94% of pediatric oncologists discuss fertility. And what basically this highlights is that there is a discrepancy between the current guidelines and the reality regarding counseling. And this is something for all of us to work on and an area for improvement to increase access to fertility preservation. So what about Yale? What is going on? How are we doing with counseling at Yale regarding fertility preservation for patients undergoing therapy for their cancer? So we do have one study that looks into how what percentage of patients are being counseled specifically for patients who are prescribed cyclophosphamide. The study included 236 reproductive age women between December of 2019 and October of 2021. And of these 236 patients, 33% received family planning counseling, and 9% were offered ovarian tissue cryopreservation. There were certain factors which modified a patient's likelihood for receiving counseling, and those included Caucasian race, age less than 40, and those who had living children were less likely to receive this counseling. So how can we improve access for fertility preservation? There are several things that need to happen for us to achieve that goal. One is to increase awareness. Next would be to assess patients' interest in receiving fertility preservation treatment, as well as the provider providing basic counseling regarding fertility preservation, placing a referral when indicated, and then ensuring that a patient is able to access this care. So how do we increase awareness? Well, patients are often overwhelmed by a cancer diagnosis, especially when they first receive that diagnosis. They can be worried about delays in cancer treatment, or they could just be unaware of the potential effects of their therapy on their reproductive capacity. The medical team already has a considerable amount of counseling to do when a patient receives this diagnosis. And oftentimes that the discussion of fertility preservation cannot be prioritized. However, the onus really falls on the medical team to be able to identify these patients who are at risk and to be able to provide basic counseling and place the referral to reproductive endocrinology when indicated. So what are some ways that we propose we optimize this awareness? So one is just through education and collaboration, which is why Dr. Glenn and I are here, is to try to promote that. And something else that we proposed was epic optimization, which we'll talk about a little bit more in the next slide. So something that Dr. Glenn and I had proposed to the EPIC optimization team is to potentially have a hard stop when a new diagnosis of cancer is entered into a patient's problem list. A provider could encounter this alert that would require that they acknowledge a reason for either referring a patient to reproductive endocrinology or not placing a referral or acknowledging that this is not applicable for this patient. After a provider is met with this alert, they would then, when indicated, either place a consult to gynecology when a patient is in the inpatient setting, or if they're in the outpatient setting, they would simply just place an REI referral. I just want to highlight here that when patients are in the inpatient setting, that consult is a general consult to gynecology. Once that consult is placed, the inpatient gynecology resident team will contact reproductive endocrinology. This can also be done for preservation for male patients. It would still be a gynecology consult in that case as well. So now regarding education, the Oncofertility Consortium was developed in 2007 to address the lack of knowledge concerning fertility preservation. And the National Physicians Cooperative includes 83 institutions, including oncologists, surgeons, endocrinologists, reproductive endocrinologists, urologists, rheumatologists, geneticists, and mental health providers. And below are also different links that can be used by both providers and patients to promote education on this topic. And then regarding counseling, so there are several steps involved in counseling patients, including informing patients of the potential risks to fertility of their therapy, as well as just inquiring whether they desire to preserve their fertility, referring patients to REI if they're interested, as well as following up on those patients. At this point, I want to just transition a bit to discuss patient perspectives, and hopefully this will help highlight again the importance of this topic. So in a study that looked at female cancer survivors, there was an increased rate of pregnancy termination among female cancer providers due to a fear of the effect of their therapies on their future children. And what this really highlights is a gap in education. This study also showed that 91% of female cancer survivors felt that their quality of life was improved after receiving counseling and treatment about fertility. There was also a cross-sectional study concerning fertility after cancer, where the primary outcome was use of fertility treatment. And in this study, 75% of participants reported that having a biological child was important to them. 15% of these participants actually used fertility services, and survivors were less likely to pursue infertility treatment due to a fear of adverse effects on their personal health, which again highlights a gap in their education. Other patient perspectives include a survey from the Journal of Clinical Oncology. In this survey, 81% of teen girls and 93% of their parents would be interested in fertility preservation, even if that method were to be experimental. In a survey from the Journal of Assisted Reproduction and Genetics, 12.5% of patients reported that they would regret if they were unable to use the tissue that they preserved for ovarian tissue preservation. And these patients and parents felt more in control of their decision with receiving this counseling. Other patient perspectives, there are studies and surveys that indicate that 26 to 80% of individuals remember discussing fertility. This range really highlights the variability in each practice. 68% of males and 14% of females remembered being offered a referral for fertility preservation. And then this last statistic reports that female survivors were less likely to be prescribed infertility medications after seeking help. And that relative risk was 0.57. And what this shows us is that there's also a lack of education among providers. So next, I'd like to speak about the different methods that can be offered to patients for fertility preservation. So there are many proven as well as experimental methods for preserving fertility. These include gamete or embryo cryopreservation, ovarian tissue or whole ovary preservation, suppression of damage, which can include decreasing the dose of a certain therapy or using an alternative therapy, decreasing the dose to the gonads or shielding the gonads, or avoidance of damage entirely, which could entail removing the gonads or using an alternative therapy. So to discuss some of the proven methods, the gold standard is considered embryo cryopreservation. This process includes stimulating the ovaries with gonadotropins, surgically retrieving oocytes, inseminating the oocytes, culturing them for 3 to 5 days, and then cryopreserving them. This tends to have a high success with 90% survival of embryos and live birth rates between 22 to 35%. This whole process takes about 2 to 3 weeks. And some of the cons include exposure to high dose hormones, the time involved, and the fact that the patient would need either partner or donor sperm. Another option is mature oocyte cryopreservation. This tends to have slightly lower success rates, between 50 and 90% survival. That's likely due to attrition of the oocytes, as they need to be frozen, thawed, then inseminated and, fertilized, and after fertilization, matured. This process takes essentially the same amount of time as embryo cryopreservation. There are fewer ethical objections, and no partner is required for oocyte cryopreservation. Another proven method includes oophoreprexy. This has a success rate between 16 and 90% and involves fixing the ovary to the pelvic brim with a surgical clip. This is typically used for patients who will be exposed to, for example, radiation therapy to the pelvis. And what it's essentially doing is moving the gonads away from that site. There are no ethical obligations. There's no ethical objections to oophoreprexy. It enables a patient to be able to use their own oocytes, and there's no stimulation required. Some of the cons include that it really depends on a patient's vascular system. It depends on their age. It depends on the dose of radiation that they're receiving. And it can also be affected if the area is not shielded. The other methods for fertility preservation include ovarian tissue cryopreservation. This was previously thought to be experimental and is now a proven method. It involves obtaining ovarian cortical tissue prior to ovarian failure. The tissue is obtained via laparoscopy or laparotomy. The tissue is dissected into small fragments, cryopreserved, and then can later be transplanted. Most typically, that's done as an orthotopic transplant and not a heterotopic transplant. Live birth rates are between 23 to 25%, and this is particularly useful for prepubescent girls, and it can also be used as a form of endogenous hormones once this tissue is retransplanted. Some of the cons include the reimplantation of potential cancer once the tissue is removed and then reimplanted, the uncertain lifespan of this tissue, the fact that it requires surgery and may require IVF down the line, and the age limit such that patients who are typically over the age of 40 will have less benefit in this case. Next, I'd like to go over just a few experimental methods, which include whole ovary, including pedicle cryopreservation. This is typically reserved for very young patients whose ovaries are very small, for which ovarian tissue cryopreservation would be very difficult. Another experimental method includes GnRH agonist therapies. The thought process with this is that we shut down the ovaries while a patient is receiving their cancer therapy. And the thought is that when these ovaries are less active, they'll be less susceptible to the harmful effects of the therapies. Some alternative options for patients include the use of donor eggs, the use of donor embryos, surrogates, or adoption. Lastly, to go over what happens post-treatment for these patients. So regarding evaluation of their fertility down the line, most reproductive endocrinologists or gynecologists would look for patients to resume their menstrual cycle, as well as test their anti-Mullerian hormone level to get a proxy of their ovarian reserve. Regarding the use of medications and outcomes for these patients, Generally, we use the same medications. However, as already mentioned, if a patient has an estrogen-sensitive cancer, we can consider adding letrozole, an aromatase inhibitor, or tamoxifen to reduce the exposure to high levels of estradiol. There are lower pregnancy rates in the first 5 years with with use of autologous oocytes, and that lower pregnancy rate is 60%. However, notably, if someone were to use donor oocytes, pregnancy rates tend to be fairly comparable. Regarding pregnancy complications, pregnancy does not affect recurrence of any cancer, and generally pregnancy complications tend to be very low. The one exception to this is that some patients who receive very high dose of radiation to the uterus, especially at a young age, can potentially have a bit higher risk pregnancy outcomes and pregnancy complications. Regarding risk to offspring, there's no increased risk of anomalies. However, a provider may consider referring a patient to a genetic counselor, specifically if there's a genetic predisposition to cancer. Some other concerns that I'd like to briefly discuss include some safety concerns. So it should be determined by a multidisciplinary team, including the medical oncologist and reproductive endocrinologist, as to a discussion of the risks, benefits, preferences, and prognosis of this patient, to discuss whether pursuing fertility preservation would be safe for the patient. There should also be consideration paid to trying to prevent any delays in oncologic treatment. Regarding the legal implications, we should acknowledge the legal implications of not following the standard of care, as well as the medical liability and potential malpractice with omission of information specifically regarding the risks of cancer therapies on reproductive capacity. Additionally, the ethical considerations to consider that every patient has the right to know their options concerning fertility preservation, as well as the risks and costs associated with that. Posthumous utilization, this typically will depend on a patient's advance directive. Minors who are diagnosed with cancer will typically require a surrogate decision maker. And of course, the cost of these therapies. Just to briefly discuss the cost, there is legislation regarding costs, specifically in Connecticut. In general, in 1942, the US Supreme Court acknowledged that procreation is a basic civil right. And then specifically in Connecticut, we do have the Fertility Preservation Bill. This was enacted, and basically it ensures that patients are covered for fertility preservation if they have a medical necessity, and having prior cancer treatment is considered, makes fertility preservation a medical necessity. And so patients who have private insurance have this cost covered under this bill. Unfortunately, that bill does not cover the cost for people without insurance or for people with Medicaid. And so there are other means to try to reduce that cost for those patients, and they are listed below. So for example, with Reprotech, they provide discounted long-term storage of ovarian tissue as well as oocytes and embryos. Specifically regarding the cost of ovarian tissue cryopreservation, that one tends to be a bit costly and can be between $12,000 to $24,000. However, this can also vary based off of the patient's income. And so lastly, to summarize some of the things that we discussed today, certain cancer treatments such as chemotherapy, radiation, and surgery can lead to sterility and subfertility. All patients of reproductive age who will undergo potentially gonadotoxic therapies should receive appropriate counseling. Some of the methods to try to optimize access to fertility preservation include increasing awareness, promoting education in counseling and collaboration, and methods to preserve fertility include embryo or oocyte cryopreservation, oophorectomy, ovarian tissue cryopreservation, or experimental methods. Thank you so much for your attention. Here are some of our references, and we're happy to answer any questions. Okay, so we have a question here regarding oophorectomy. The range of success rates listed are quite wide, from 10 to 90%. I had heard roughly a 50% chance of damaging the ovary directly from the procedure itself, which seems a high risk since the risk from radiation is also probabilistic. Does Yale offer this option? What do the success rates look like in modern practice? And what patients do well versus poorly with this approach?
Wonderful. I actually have not seen oophorectomy done here at Yale, but it is actually a simple procedure. It's the same thing if we had someone with an ovarian torsion. It's actually the same procedure to be done. So it's something that we can absolutely do. I haven't seen a whole lot of pelvic radiation patients come through. I couldn't give you the exact statistics, mainly because the problem is like it varies on dose, where it's located. Are they shielding or not? And so that's why you see that wide range. So even with oophorectomy, we'd probably still recommend doing an additional fertility preservation procedure like tissue or embryo cryopreservation, just to make sure that if there's any scatter from the radiation, that we're still protecting them as much as possible.
So I have a question for you. So, obviously these issues come up with a fair amount of frequency. I'm struck that you gave a great talk, but one of you is going off to take a job in Texas, and Gabriela, you're going off to do a fellowship in another year. So who on the in the REI faculty is interested in these issues, who we should approach?
Well, Gabby's been here for another year, and so
I understand. I understand that, but again, still in training.
No, absolutely. And so we're working with Dr. Callan as well, and she does mainly probably the most of the fertility preservation, but the fellows all work together too. So everything's just kind of passed down for. So my second year fellow, who's a rising third year now, Eric Hahn, would be another good point of reference as well. I think there's another chat.
There are questions.
Can you talk a little bit more about your outpatient services? How quickly can these patients be seen, particularly those who need to start anti-cancer treatment quickly?
Absolutely. So usually the third year fellow actually does all of the, at least the Medicaid referrals and other referrals as well. If you just mark them urgent, we usually can see them within a week, if not faster. Inpatient, of course, we see within 24 hours. A lot of times it's just via like video chat. So we can just talk about the options and start getting things set up on our end. But usually we see people very quickly. We manage to squeeze them in somewhere because we know how important this is. And, the hard part is when patients, are not stable enough, and those are probably the hardest patients. And so usually if they have to undergo cancer treatment immediately, we want to make sure that they know how to find us afterwards so we can start planning after their treatment as well. Oh, Kurt, is there any movement to extend reproductive coverage to patients with Medicaid? I wish. I've not seen any movement, unfortunately, for that. I think there's an ongoing struggle. The hard part too is, I'm not originally from the East Coast, but since all the states are so small, each time you move states, we see a lot of patients from Rhode Island and Massachusetts and New York, and all of those states have different policies when it comes to fertility preservation. And so it makes it very difficult to keep up with everything. But I have not seen any improvement in that area.
Can you clarify if the quality of life statistic is independent of whether or not the patient used preservation strategies? I think this stresses the importance of referral regardless of whether or not you have time. Yeah.
Yes, it does. Patients, even if they cannot pursue the treatment, especially if they can't pursue it immediately, still appreciate the counseling that they receive so that they're aware of it. It's not 10 years down the road that they're surprised by this outcome. Something as well is that we're doing a lot more ovarian tissue cryopreservation. Dr. Akhte, who's a Yale physician, but recently has been working a little bit more with us. He does the ovarian tissue cryopreservation. He kind of based out of New York, but then he comes down and he does ovarian tissue cryopreservation and does a lot of research on fertility preservation. And so we're lucky to have him and that we can kind of continue to pursue. Other areas that we're trying to improve on is, testicular tissue cryopreservation. Hopefully we will get more. There's only like one area, I think in Philadelphia or Pittsburgh around here that does that for prepubescent boys. That is still experimental, but there's a lot of different things that we're just trying to bring more to Yale so that we can ensure that we kind of cover everyone for fertility preservation. When it comes to male fertility preservation, it's usually if they're postpubertal, very straightforward. If there's any problem with ejaculation or the patients are unable to do so, we just have our colleague from urology, Dr. Honig, help us with that. But we have our own andrology lab and store sperm here.
Any other questions? Well, thank you both. It was really great. And we look forward to interacting with your colleagues in the years ahead, and good luck in